Welcome to AETCM, the emergency medicine channel. Today let us discuss about one important infection, that is infectious mononucleosis or IMN. IMN is actually a syndrome. It can be produced by Epstein-Barr virus, CMV, other type of herpes virus. And this type of syndromes like IMN-like syndromes are seen in various other clinical conditions like it can be due to adult onset Still's disease. It can be seen in HIV-induced acute HIV reaction. So many conditions IMN-like syndromes can be seen. But 90% of the patients, this disease is due to Epstein-Barr virus or human herpes virus type 4. It's a member of herpes viridae family and it's a DNA virus. Here the patient mainly present with high degree fever, skin rashes, pharyngitis, weakness, lymphadenopathy. Some patients may have prolonged post-viral lethargy, weakness like that. About 5 to 7% of the patients, this mononucleosis-like syndrome can be due to CMV, cytomegalovirus, other types of herpes viruses, Toxoplasma gondii, adenovirus, adult onset Still's disease. It's a rheumatological condition where the patient can have high degree fever, along with patient can have skin rashes. They also have IMN-like features. They can have pharyngitis, some lymphadenopathy, non-specific lymphadenitis. All these things also seen. The spread of the disease is mainly due to droplet infection, saliva. That's why this is otherwise called as Kissing's disease. It's very common among college students. Epstein-Barr virus is a cause of erythrophil positive infectious mononucleosis, which is characterized by fever, sore throat, lymphadenopathy. These are the triads of the disease: high degree fever, sore throat, congestion of the throat, then lymphadenopathy. So any viral fever who is having cervical lymphadenopathy, we have to always suspect infectious mononucleosis. This is otherwise called as glandular fever. That is because of this lymphadenopathy. Atypical lymphocytosis is seen in peripheral blood smear. That is another major diagnostic feature for this IMN. Now transmission is mainly through oral secretions, oral or nasal secretions. This is sometimes called as Kissing's disease. So this is mainly caused by Epstein-Barr virus. Some patients may not have symptom at all. They may be having only minimal weakness or some mild sore throat, but they are carriers of this disease. They can spread the disease from one person to other person. So all patients may not have typical symptom of this disease. Some may not have symptoms at all. Acutely, Epstein-Barr virus produces IMN-like features like sore throat, fever, rashes, atypical lymphocytosis, cervical adenopathy. But some of these patients who have past history of this disease, sometimes clinical history may not be there. They can progress to nasopharyngeal carcinomas, Burkitt's lymphoma, Hodgkin's disease, B-cell lymphoma. So there is a chance of progression of this infection towards B-cell malignancies. But that incidence is not very well known because unfortunately we may not have the actual number of the infectious mononucleosis infection. Those who are coming to the hospital with IMN-like symptoms, if the antibodies are positive, then only if you follow up these patients, you can know whether they have developed any complications due to IMN or not. But as of now, some of these malignancies are known in chronic infection of EBV. Now the major features are fever with chills, sore throat. You can see the tonsils are congested, lot of pus will be there, pain will be there, difficulty in swallowing will be there, sore throat will be there. And many patients after initial symptoms, they may recover without any complication, but their fatigue, weakness may remain for a longer time. Around 6 months, this post-viral convalescent period may occur, and they may have continuously have reduced energy, weakness, lethargy, feverishness feeling, evening feverishness feeling. So this sometimes mimic tuberculosis also, because when the patient present with high degree fever for 1 or 2 weeks, one of the problem in IMN is the fever itself can prolong. Normally viral fevers will subside in 7 days, but in IMN there is a chance of prolonged fever in IMN or feverish feeling in these patients. So actual fever may come down, but for 1 or 2 months patient will have persistent feverish feeling, especially in the evening hours. If you examine the patient, you may not see any fever by thermometer, but patient may complain that feverishness, chillness, all these things. Now, lymphadenopathy is very classical in this type of fevers. Patient can have cervical lymphadenopathy. They are not firm, but they are not soft also. Sometimes it will be tender lymphadenopathy. Since it's an acute problem, most of these nodes are tender. That is a problem in this type of acute infections. But there is a strong differential diagnosis for this type of acute lymphadenopathy, that is lymphoma. Lymphoma also present typically like this, but their nodes are slightly rubbery and it may persist for a longer time. The second important differential diagnosis is acute HIV syndrome. A patient who develops acute HIV just mimic infectious mononucleosis. They also have pharyngitis, they also have cervical lymphadenopathy, they also have fever. So all these things mimic there also. Now other signs: generalized maculopapular rashes, urticaria, petechial rashes. But one important problem in infectious mononucleosis, you know that many of the doctors, they give antibiotics in fever. Without investigation, sometimes we may be giving antibiotics in a viral fever also. That's actually wrong. But sometimes when we give amoxicillin or penicillin group of drugs like amoxicillin, clavulanic acid, in a patient who is having infectious mononucleosis, there will be severe rash all over the body. But that doesn't mean that patient is allergic to penicillin. That's a part of infectious mononucleosis. So any patient who develops rash after amoxicillin, you have to think about infectious mononucleosis. So that is not due to penicillin allergy, it is a part of infectious mononucleosis. So this is a very classical finding. Infectious mononucleosis developed rashes after taking amoxicillin, augmentin, ampicillin, this type of drugs. Palatal petechia or palatal rashes are very common in infectious mononucleosis. Periorbital edema, that is seen in many types of viral fevers, including infectious mononucleosis. Splenomegaly and hepatomegaly. This virus mainly affects the lymphatic system or lymphoreticular system of the body. So spleen and liver will also be enlarged. So if you take Hodgkin's disease or non-Hodgkin's lymphoma, there also all these features will occur. Patient will have high degree fever, cervical lymphadenopathy, hepatosplenomegaly. So lymphadenopathy itself is not a disease. It may be a part of the other major problem like lymphoma or tuberculosis. But infectious mononucleosis is an acute problem. It comes in less than 3-4 days. Patient will develop all symptoms: fever, rash, lymphadenopathy. Most of the patients, the symptoms will subside in 1 week. If the symptoms are not subsiding in 1 week, then it creates problem, because acutely we don't take any lymph node biopsy. But if the lymph nodes are persisting after 1 week, it is better to take lymph node biopsy to rule out other causes for lymphadenopathy. Autoimmune hemolytic anemia can be there in many types of viral infection. Here also it can be seen. So if you see the peripheral blood smear, you can see schistocytes, fragmented RBCs, new RBCs, young RBCs. Bone marrow will be overproducing blood cells. Bilirubin may be elevated. Indirect hyperbilirubinemia can be there. LDH may be elevated. That is also part of hemolysis. So Autoimmune hemolytic anemia, that is very common in this type of diseases. It's a cold agglutinin hemolytic anemia. Complication: normally these patients have acute pharyngitis, chronic fatigue syndrome, and many patients develop rashes on ampicillin or amoxicillin. Rare complications: many patients can have polyneuropathy, cranial nerve paralysis, transverse myelitis, meningitis, encephalitis. Hemoglobin percentage can come down, severe anemia, granulocytopenia, thrombocytopenia. Thrombocytopenia is seen in almost all type of viral fevers. Here also thrombocytopenia will be a dominant feature. Spleen enlargement is very classical in this disease. Very rarely splenic rupture can occur. That is especially if the patient is in an endemic area of malaria or spleen is already enlarged. There is a chance of additional enlargement of spleen and splenic rupture. Autoimmune hemolytic anemia, cold agglutination hemolytic anemia is classic. Glomerulonephritis, interstitial nephritis, pericarditis, pancarditis, interstitial pneumonia. All these complications can occur rarely in patients who is having IMN. Lymphocyte counts are elevated in patients who is having most of the viral fever. Here also lymphocytosis can occur. And peripheral smear shows atypical lymphocytosis. That is also classical. Atypical lymphocytes defined as more than 10% of the total lymphocytes are atypical. Then you can call it as atypical lymphocytes. Mild elevation of SGOT, SGPT is in many viral fevers. Here also you can see SGOT, SGPT will be elevated. Then diagnosis, you can do ELISA test or monospore test that will give you the diagnosis of infectious mononucleosis. That will pick up the antibodies against infectious mononucleosis. So atypical lymphocytes are very important. You can see the normal lymphocytes in the first figure. Second figure you can see the atypical lymphocyte. So atypical lymphocytes more than 10% in the peripheral smear give you a diagnostic clue for infectious mononucleosis. Now, once you diagnose infectious mononucleosis, we should know that it's only a viral disease. There is no antivirals effective against infectious mononucleosis, and it is a benign disease. Most of the patients, it will recover without any other complication. Only if the patient go to complication, you may have to support the patient. Otherwise, like any other fever, we have to give paracetamol to control the fever. We have to give IV fluids to improve the hydration in the patient. We have to support the patient with the calories. You can give DNS or 5% dextrose. You can give multivitamin injections, tablets, whatever required. And steroids have got limited role in this type of diseases, but many viral diseases including H1N1, COVID, dengue fever, early steroid shows that the hospital recovery will be faster in patients who is having viral diseases. Very few viral diseases you are not supposed to give steroids, like HIV, hepatitis B, hepatitis C. Almost all other viral fevers safely you can give steroid, but if needed only we have to give. Unnecessarily we should not expose the patient to steroid, like a patient with infectious mononucleosis. There is no other symptom, mild fever is there, sore throat is there. Unnecessarily we should not give steroids. If the patient is having immune mediated problem like immune mediated hemolytic anemia, thrombocytopenia, or severe myalgia, CK is elevated, something like that, the patient is going for an immune phase, if you are suspecting, then better to start the steroid early itself, because we can see many patients who is getting steroid, they recover very fast from the immune mediated phase of many viral infections. But it is not mandatory to give steroids in all these patients. That all depends on the clinician's experience whether to give steroids or not. But indicated treatments are only paracetamol, IV fluids. Pharyngeal edema, you can again give steroids. If the patient is unable to breathe or take oral fluids, you can give steroids. Proton pump inhibitors can be given because they have severe gastritis. Other supportive measures should be given. Then penicillin, anyway we should not give any antibiotic this type of diseases. If you know that it's viral fever, initially in emergency room you can see the blood counts will be normal, procalcitonin can be done, that may be normal. Once you know that it is a viral disease, most of the viral diseases there is no treatment available. H1N1 you have treatment, oseltamivir is there, but even COVID also there is no effective treatment, effective antiviral. Many other viral diseases also there is no effective antiviral. So better to leave the patient without starting any antiviral drugs. Only supportive therapy is enough. Complete bed rest is required in many patients who is having viral fever, because many patients after exertion they develop myocarditis. That is one of the major complications of most of these viral fevers. If you do severe exercise or exertion during the recovery phase of viral fever, you can see many patients develops cardiac failure, myocardial infarction, all these things during the recovery phase. So try to avoid severe physical exercise or exertion during the recovery phase of the disease. And one more important thing is many patients who is having infectious mononucleosis, they go to the phase of prolonged recovery. So they have long-term complication because of this disease. They have severe weakness, lethargy, laziness for a longer period after infectious mononucleosis. So we have discussed about one important and common infections which can come to emergency room. It's a highly contagious disease. We have to be very careful when we are dealing this type of patients. It can spread from one person to other person very fast. This is infectious mononucleosis, Epstein-Barr virus. Very common disease among young patients. They have fever, rashes, oral congestion, pharyngeal congestion, and lymphadenopathy. This is sometimes called as glandular disease. Lymph nodes are enlarged. There are a lot of differential diagnoses. Many viral fevers can present like this. HIV syndrome can acute HIV syndrome can present like this. Toxoplasma can present like this. And one important rheumatological condition, that is adult onset Still's disease, that also can present like this. So it is always better to do, whenever you are seeing lymphadenopathy, pharyngitis, it is always better to investigate for infectious mononucleosis like antibody test, monospot test. And once you diagnose, there is no major treatment, only supportive therapy is enough. Most of the patients will recover by 7 days. If there is a prolonged problem, or if there is a immune mediated problem, or if there is a severe edema on the throat, then steroids are helpful. Otherwise paracetamol alone is enough in this patient. Try to avoid penicillin group of drugs in this type of patients that can produce severe rash. Thank you.